work a lot with neurosurgical faculty at this career stage, and I'm happy to help out. And then through a series of emails, this morphed into, can you give a 2 to 3 hour interactive workshop on study design? And I had sort of agreed at the outset, so I didn't feel like I could back out at that point. But anyway, so this is a little bit of an experiment. I've done this before, but I've never done it before with this audience. And so I obviously recruited some help for today. So I think what I'd like to do is first just quick introductions, and then I'll give a little bit of background, and we'll have a little bit of didactic material on ethics, and just on a little bit of background on neurosurgical study design, and then kind of have a discussion-based exercise. So, as I said, my name is Chris Butson. I'm a faculty member in the Department of Biomedical Engineering at the University of Utah. I'm also in the Scientific Computing Imaging Institute, named the SKI Institute for short, and I'm appointed in, I'll talk more about this in a minute, but I'm appointed in 3 clinical departments. So the animal of choice in my lab is humans. So we do all human subjects research. And yeah, Aniko, why don't you go ahead?
Okay, so my name is Aniko Szabo. I'm professor of biostatistics at the Medical College of Wisconsin, and I run the consulting service for the past 20 years probably, so I have seen lots of the grants and study designs and trials.
And so Aniko and I have collaborated on grants and papers for, I don't know, about 10 years or so, when I was in Wisconsin and then I went to here.
I'm Melissa Butson, and we do go together.
We collaborate.
We collaborate. I have a PhD in empirical bioethics from Case Western Reserve University, and today I think I'm the token bioethicist to talk to you about research ethics in human subjects research.
I'm Andrew Jansen. I'm a biomedical engineering PhD candidate in Chris Butson's lab.
Great. So maybe what we can do, or what I can do, is just start out with just a general introduction, and then Melissa, I'll turn it over to you, and then we'll kind of get into looking at 1 or 2 cases of neurosurgical trials and have some discussion about it. So just by way of introduction, so I have been continuously appointed in neurosurgery departments since 2008, and almost all the grants in my lab are multi-PI grants with physicians, mostly neurologists and neurosurgeons, sometimes psychiatrists. And I have quite a bit of experience with reviewing training grants and also research grants, and also applying for them. So I think in the last 5 years, 11 of 14 training grants have been funded that I'm the primary mentor on. And these are through NIH, National Science Foundation, and also the University of Utah. And then just parenthetically, Jeff Ogeman yesterday morning when he was talking said something about how I was like highly critical of some grant. I don't feel like I need to defend myself or any kind of rebuttal, but I'll just point out that when I was on study section to review K and F grants, I was a very vocal supporter of applications, especially from neurosurgical trainees. And what I really tried to do for the study section was just sort of articulate some of the differences about their training and career path that I just think probably were not obvious because they're just so used to seeing PhD candidates come in. Okay, so not a defense, but anyway, I just wanted to point that out. And these are just some recent study sections over the last 5 years. And in preparation for this, I took a quick look at publications and presentations specifically with neurosurgical faculty. And so I've had a fair number of these over the years with neurosurgical faculty kind of at all different career stages, ranging from fellows to full professors. And I guess that the reason that I'm telling you this is partly just that I am immersed in, in a particular specialty because I study medical devices and implantable devices and neurostimulators. The neurosurgeons I work with, their specialty is almost exclusively functional neurosurgery. So I don't work a whole lot with other specialties, but within that specialty, me and my lab and also when I do grant paper reviews, we are immersed in that process, doing retrospective and prospective surgical studies. And the last thing I'll say about that, and this is part of the motivation for just for this workshop, is we've done studies in my lab and we've been involved in trials where I sort of know, in quotes, deep in my heart that this therapy worked, and yet we failed to reach our primary endpoint. And then we just had to report that, in the paper, like failed to reach primary endpoint, endpoints were not significant, and there was all kinds of fallout from that. But I spent a tremendous amount of time and energy thinking about this type of problem. And I think that we also agree, especially when it comes to experimental brain surgery for new indications, the stakes are really high. They're high because usually the patient populations we start out with are just like the worst of the worst. I mean, as rational people, these are not populations you would want to start with. You would want to start with something maybe a little more moderate. But the reality is that these are the severe cases who are usually refractory to other treatment approaches and are willing to consider experimental brain surgery. So the stakes are high for us as scientists. Obviously, the stakes are high for the subjects and the participants who choose to come into these studies. So that's just a little bit of my background and motivation and kind of how my work fits in with the subject matter today. The other thing that I'll just say by way of introduction, and this is something that almost never gets talked about, and I'm not sure this is the right venue to talk about it, but I've got to mention it somewhere, and this is as good a place as any. So this is my impression of what it's like to be a faculty member. So the upper limit on demands of my time is infinity. And I don't need to be explaining this to this audience. You know better than I do for multiple reasons. And the reason I'm concerned about this, especially with grants, is because the length of grant applications keeps steadily creeping up over time, and the number of sections we have to fill out keeps increasing. And the sections that we, as faculty, review on study section, obviously, I mean, we have to read like 100 of these. And the realities of this, I think, need to be talked about at some time. And I don't know if this is the right time or not, but I think we need to have some kind of upper limit on the number of pages in the overall application or the number of sections. I'll also just point out the obvious: increases in R01 budgets since forever has been zero. So the realities of trying to do human subjects research within a $500,000 a year budget for 5 years, that indirectly keeps shrinking over time. I think the increases in NIH salary caps, there have been modest increases over time, but as you know, these limits are just nowhere near the salaries for neurosurgical faculty. And this came up yesterday, and I'm sure it comes up in other venues too, that if you're a successful neurosurgical clinician scientist, that your department and your department chair they are sort of subsidizing your salary to some degree, because the NIH salary caps will usually just cover kind of a fraction of that. Steve talked about that a little bit before, about effort versus salary and making those distinctions. But there have been some adjustments there, so that's good. And the last thing I'll point out is just what I call the value proposition for doing research, especially for physicians. So my training is all in engineering. I have degrees in 3 different areas of engineering, most recently biomedical, and that's kind of my life. But for clinical faculty, there's many different ways that you can go through tenure and promotion. There's many different tracks that you can be on. And for those of you who, like this audience, who are on track and are already clinician scientists, I think you have to figure out what is really the value proposition for doing research. And so as a specific example of that, I'm a faculty organizer at the University of Utah for what's called the Neuroengineering Research Group, which is this broad university-wide group of people interested in neural engineering. And I thought it would be helpful and have a workshop on training grants for scientists in training. And we had all these, really, it was quite good. We had this panel of people from the Office of Sponsored Projects and people who taught classes and people who led centers and institutes, and we had this panel discussion. And what I realized, it was like an hour long, and about 45 minutes into it, I realized, wow, it's very informative, and it's very accurate, but it's also almost all gloom and doom. It was just, funding rates are low, and it's just, and everything about it just sort of sounded negative. And so I stopped, and I just said, on some level, this has to be rewarding and fun, or there's no reason to do it, right? And the rewards for people who go into research and get grants funded are different than maybe people who are full-time clinicians. So the reason I bring this up is I think it's important for each of us as individuals just to kind of articulate this. So I don't know if these are things for discussion today or not. We can sort of see if they come up.
Can I bring them up?
Sure. Oh, I'm sorry. Shai. Well, everybody knows you because you gave a talk yesterday, but I didn't introduce you as sort of part of the panel.
So I wanted to comment on some of these things. So as far as the increase in budgets in R01, there's no limit to the size of an R01. As long as it's justified. Now, if you go over 500K per any given year, you have to get pre-approval to come in. But aside from that, there's absolutely no limit. So let's knock that one off.
Can I get a rebuttal? Keep going.
As far as page limits, so the actual grants themselves are unfortunately now limited to 12 pages for an R01, which I think was a huge mistake because if you haven't figured this out already, it's infinitely harder to write a short grant than a long grant, okay? Because how do you fit everything into 12 pages? Okay? Now the additional stuff, yes, there are, but not that many. So they added it, in the last few years they added the page on authentication. That's all they added. I think at the institutional level, there you see much more regulation on the investigators. And that's an issue that has to be addressed and somehow it has to be reduced. I 100% agree with that. So yeah, I guess those are my comments on at least the NIH side. I'd say I'd say also something on the salary caps. Okay. Everyone is unhappy with the pay line at NIH. Everyone would love to see it at 25, 30%. Okay. But there's a certain amount of money. So any money you take away from that budget for any category is going to reduce the pay line. So so that's one of the reasons why NIH put a cap on salaries, because otherwise, there'd be much less money to do the research. So there's logic behind it, and neurosurgeons have to come up with a difference somewhere. But I don't think we would want NIH to have less money for doing research.
Sure. Yeah, absolutely. I will point out, some of you may know this, National Science Foundation does not have salary caps. So if you have somebody on who you know has a large salary, then we sort of do something similar. We say, well, we can only afford to put you on at like 1 or 2%, and sort of explain why that's appropriate. Yeah. Okay. So maybe what I'll do is I'll turn it over to Melissa to talk for a few minutes about research ethics and the protection of human subjects. And you can just tell me when you want me to.
Okay.
Sure.
Just the arrow.
Spacebar.
Okay, hi. Sorry for the frog in my voice. We have sickness in our family. I'm just going to talk really quickly about research ethics and the protection of human subjects. I think I understand that you have all written grants to be here today. So I know that you have gone through the most basic training, at least, to attend to that portion of the application. So this is likely to be a type of review, but it's important, and I think the more that we can get it into, these are so tiny, into your head, or all of our heads, the better. I'm going to just mention the 3 main ethical principles that underlie the conduct of biomedical research using human subjects in our country, from the Belmont Report. How those 3 principles translate into practice when we're doing research, and then if we have time or interest, or if the powers that be decide we should, we can talk about a few of the ethical issues in the design of your research. My background is in research and genetic testing, so how to deliver genetic testing results and what the implications are for those. So my personal background of the ethical issues in my research are likely to be somewhat different, but we all have common concerns, I know. So the Belmont Report, which is from 1979, outlined the 3 main ethical principles that we need to always have in mind and that will guide the ethical conduct of human subjects research. The first being respect for persons. Sometimes we call that autonomy. All right, so we know that, and these are normative ideas, right? These are shoulds and oughts. Individuals should be treated as autonomous agents. People should be allowed to make their own decisions about their own bodies and healthcare. We also believe that individuals who have diminished autonomy or capacity should be protected. The next principle is beneficence. And as physicians, the do no harm piece is huge. In research, we can't usually say that because maybe we're doing the research because we believe that the current technology might be harmful and we need to decide if there's something better. And we can never say that there will be no harm. So what we ought to do is justify our research in a way that maximizes benefits and minimizes harms. So there's an assessment that has to be done there. And then the last piece is justice. And in this case, what we're usually talking about is distributive justice. So what we mean is that the benefits of research as well as the burdens of participation should be distributed fairly across a group of people. And these principles sometimes come into conflict with one another, but they provide a really interesting and solid way to proceed with deliberation when you're trying to decide on the next course of action. These 3 principles translate into practice pretty directly. So with regard to respect for persons, that drives the informed consent process. One of my personal pet peeves is that consenting isn't a verb. You don't consent somebody, or we obtain informed consent, and it's a very deliberate mechanism. It's not perfect, and we don't have perfect ways of assessing it, but it's so, so important, and I'll have another slide on that in a second. With regard to beneficence, we talk about the assessment of risks and benefits, as I mentioned previously. We need to make sure that we are not asking people to take large risks when we don't anticipate any benefits. We need to think clearly about what that ratio is going to look like. That's important for us, and it's important when you're talking to people who are trying to make their own judgment about whether or not they should participate. And lastly, justice sort of translates to the selection of research subjects. So we want to do an equitable job when we're choosing our research subjects. The three main parts of informed consent are information, and that's, I think we get caught up a lot on the information. What's going to happen? What is this about? What is it going to look like for you? Who do you call if you have a problem? That's the starting point. People have to know what they're signing up for. Comprehension is a beast, honestly, especially in the research that I was doing on genetic testing. People, you might think the first good step would be, can they repeat back to you what you just told them? And actually people can kind of do that. And that has nothing to do with comprehension. It's sort of listening and repeating. So it's very difficult to assess comprehension. But it's important because then it's not informed, it's just consent. And voluntariness is the third really important piece, and that's where we get into concerns about undue influence and coercion. And so we need to make sure that people are doing this of their own volition. With regard to beneficence, people often say that we need to assess risk and benefits, equating risk and benefits like apples to apples. But really, the concept of risk implies both probability and magnitude. So there are two sort of axes to a risk. So I think it's better to talk about weighing harms versus benefits. That's the parallel construct there. And risks as compared to the probability of benefits. So we need to be talking about how likely things can be and how good or bad. One pretty typical misstep that can happen sometimes is getting too concerned about physical harms and neglecting that there could be other harms involved, like psychosocial harms. Could be anything from like identity for deep brain stimulation for depression or something. Who am I without my depression? What does it mean that I can dial myself up or down? There could also be legal and economic consequences, especially, for example, in genetic testing research. Having certain information about yourself can have consequences that are not just physical. They can prevent you from getting insurance, for example. With regard to justice, there are two components here as well, on an individual basis and a social basis. So individually, participants need to be selected without favor or bias in a fair and equitable way. Meaning, if you believe in your heart that this subject, or that research might work, and this is probably a really good idea, that you only really want to ask the patients that you really like. Or if you think something is kind of risky, then you'll just ask the people that you don't really like. But really, the social justice part of it is about groups and considering the burdens that might be placed on groups with regard to their participation, as well as with regard to what the results might say. So for example, it's really convenient to want to do research on prisoners or people who are institutionalized for their mental health care. But they're already quite burdened. It may not be fair, and they may not be the ones who get the benefit of the results of the research. So it's really important to think about which groups you ought to include or ought not to include. Or for example, we often don't include children because the risks are just too great, and we prefer to do our experiments on adults. You said something earlier about experimental brain surgery, and this is one of what I think is one of the more interesting sort of ethical conundrums when we're doing research, and that's a therapeutic misconception, this conflation between healthcare and research among the patient participants. And it's understandable, for example, if you say something like experimental brain research, that might mean, well, the things that we usually do, we don't think are going to work anymore. I want to try something else on you as your doctor. But that's not research, right? Research is something to generate generalizable knowledge. And So even we can conflate it in our language sometimes. So a therapeutic misconception is one of the issues that I just wanted to mention because you just said that. So I can stop, but it could be interesting to see. I wanted this to be separate because those are my ideas. If I wanted to see if anybody else had any ideas about some of the issues that come up in neurosurgical research that have to do with ethics. I could do this all day. I know that's not why you're here, so I could pass it on.
So, yeah, if there's any immediate questions, we can field those now for kind of just getting into an exercise, or I think a lot of these things are naturally going to come up.
Let's do that.
Okay. All right, great.
I have one quick question.
Yeah.
On the protection for human subjects. I know Steve Corn's not here. Protection for human subjects, is that unlimited in space? And how much you get, in terms of pages for K or R grants?
I believe it is. I believe it does not have page limits. I don't know, Shai,
Yeah.
you know? Off the top of your head.
The
Protection of human subjects. Are there page limits on protections of human subjects?
I don't know, I'm sorry.
Yeah, I think there are not limits.
Yeah, I don't think they're okay. That's what I thought.
Yeah.
I want to make sure before I resubmit.
Does the same hold true for animals?
I believe so, but
I don't think there's a limit on the vertebrate animal section, is outside the 12-page limit.
But be careful with it because, I've been dinged by reviewers where they've read that vertebrate animal section and felt that there was stuff that was in the vertebrate animal section that should have been in the research methods.
yeah.
And they're critical of it, so
That's a very good point. If you try to circumvent the limit of pages by putting it into the vertebrate animal section, we're screwed.
And what were they concerned about there? Was it like, can you elaborate more on that? Because that could happen even for also human subjects where you're trying to.
Sure. I think the concern is the reviewers think somebody's trying to circumvent the
Yeah.
page limits by putting stuff. Is that what you meant? Or something
Yeah,
It
different?
is, but I'm just curious, exactly what
it's
kind of
challenging
comments there.
because,
Yeah, you're-
as you mentioned, there's only 12
That's right, yeah.
pages. And so you want to explain everything
Yeah.
in as great a detail as you can, but you're limited. And so you're this conundrum of what to include in your research method. And then you have the vertebrate animal section, and you want to be specific there. And so even if you don't intend to circumvent, it can be interpreted that way. And they are critical of that. They'll say, this should have been included in the research methods.
With respect to the vertebrate animals, at least in the last year, there was a very specific document that was released through the NIH that basically tells you exactly what to include to a T. So I think that if there's any question, it's easily searchable, and that's what I used to construct is that section.
But the human subject, so I got hit on my K for that, and in terms of safety for one of my aims, which is in humans. This is epilepsy patients, and so, but it required a pretty significant amount of effort to put a lot of that into the methods or into even a K where you're really limited on what you can write, and so I put a large part of the safety. So it's pages into that protection for human subjects. That's why I was kind of wondering, I guess, how much, what's...
So it's, I believe, and Shai or others from NIH can correct me if I'm not remembering this exactly. Protection of human subjects, I don't believe is scorable by itself. Right? It's after, I'm trying to remember the sequence.
It's after they give the scores.
After the discussion and after the scoring, was this acceptable or unacceptable? So in theory, depending on how that particular study section was run, it shouldn't, I don't think it should affect the score. Now, I have no insight into how the program office handles this. In other words,
I can tell you.
Yeah.
So it's not supposed to affect the score. And what happens is if you're dinged for, that it wasn't appropriately addressed, then when it comes to program, you can't get funded until you address these issues. Okay? So that'll be with negotiation with the institute with program about, submitting an appropriate a document and so on. So that's done afterwards. So when you submit your, assuming, you got a great score, you're gonna be funded, and you submit your just in time, the document that this kind of all your funding and all, so that's prerequisite for getting the award. If there are any issues that came up, if it's issues with vertical animals or issues with human subjects, they will have to be dealt with at that stage.
Since we're talking about this, I'll just say one other thing that I see quite often on training grants, and that's training in responsible conduct of research. And it's so simple, but I just want to tell everybody, follow the instructions. 50% of people don't follow the instructions, and they get dinged for it. And the way they don't follow the instructions is they write a whole lot about what they've done in the past for training in RCR. Nobody cares what you've done in the past. Everything in that section is in the future. Okay, so this comes up in probably half the grants that we review, training grants. Okay, so let's switch gears and just take a look at, this is a study published in Neurosurgery in 2011. And so this is a device study, and it was a company-sponsored device study. So it was North Star Neuroscience conducted a study of epidural cortical stimulation of the left dorsolateral prefrontal cortex, the LPFC, for refractory major depressive disorder. And I am an author on this paper, although I wasn't directly involved in the study. I mostly helped, once the study was completed, with data analysis, and I helped them kind of put this paper together. Okay, so this was a sham-controlled crossover study of 12 patients. And so let's just take a quick look at this, and I just want to use this sort of as an example and just hear what people think about this study design. So I'm going to skip ahead to the figures and tables. So this says 12 patients were implanted, 1 committed suicide, and this just has some descriptive statistics about who they were and number of failed treatments, and then time since diagnosis. And this is the timeline. So there was a baseline period. The stimulator was implanted. They went into a blinded crossover period where half received sham stimulation, half received 50 hertz continuous stimulation, and then they crossed over at 8 weeks, and then went into both, eventually made it into an adaptive protocol, where the stimulation settings could be titrated outside of the specific guidance of the clinical trial. Okay, and so this was that guidance. So 8 weeks of 50 hertz stimulation. Was it effective? Yes. Continue. Effective. Yes. Continue to follow up. You can just sort of follow through this. No. I think there's some information in here that did not make it, because there's a little more detail here. But you can sort of get the idea. During this period, they would test the intervention, see if it was working. If it wasn't working, they had alternatives for where to go. So just, like first impression, what do people think about this study design? So in other words, and this is an open-ended question, right? So in terms of kind of the...
how are patients recruited?
How were they recruited? So they were recruited at 3 centers through clinical practice of the PI, the study PIs. Let's take a look at this study design. Like, does this seem like just at first glance, a good study design? So, does anybody who thinks this could be improved? This design.
blinded?
Yeah, it's randomized.
Is it blinded? Is it randomized? Is it
Yes. So let's see. Let me just go back to the abstract. So it was this was a randomized, single-blind, sham-controlled study, and it says here the methods. There was a 104-week follow-up period, so 2 years of follow-up. So now let's go back to this chart.
and what was your primary outcome?
Right. So primary outcomes were 2 depression rating scales, Hamilton and Montgomery-Åsberg depression rating scales. And there were 2 secondary outcomes. One was a global assessment of function. The other one was a quality of life measure.
At 8 weeks or at 2 years?
At 8 weeks.
I was still like to ask how the patients were recruited. Was every single patient asked in their clinics? I mean, that all goes to some of this, you know, in terms of protection of human subjects. There was a lot of that and bias and so forth. I mean, only 12 patients were included in this. How many were included?
I mean, they're screened.
Yeah, I mean, screening, how many included?
Yeah. And, oh, go ahead.
Yeah, so 12
How
out of 12
severe?
or 12 out of 100? Yeah.
Exactly. How severe are these patients? What mentally not?
So I'm looking to see if. So what was the last part? Oh.
No, I just seem like, you know.
Yeah, so I'm looking to see if they say how many patients were screened.
But it does go back to your question about undue influence, or,
Yeah.
and that's not a thing that's done on purpose by anybody. But if you have a relationship with a patient and they trust you and you're caring for them, and their family loves you, and you ask them to do this, you might be more inclined to say yes than they would otherwise.
That's right. I mean, for example, but at epilepsy, and basically every single patient that has electrodes, and they're eligible for, I ask if they want a brief risk base, so there's no bias whatsoever. And you know, so I know those numbers, I can report those numbers, it's easy. And I also say, not just what I'm doing in terms of those subjects, but then what tasks they've opted into, and what tasks they don't want to opt into. So I just think it helps to prevent some of the bias.
Yeah.
My question is, are they trying to compare the continuous stimulation efficacy versus adaptive, or whether either of those is more effective than no stimulation?
So that's a great question, and you really have to dig into it to find out that with the study design.
Or should be counterbalanced, first of all. Like some of it should receive adaptive first, you know, if you aren't trying to define.
Mm-hmm. So part of the problem here, just at first glance, is this 8 weeks. Now you're bringing up what happens beyond the 8 weeks as well, but they didn't have a primary endpoint. The primary endpoint was at 8 weeks. Yeah.
I guess what I'm not sure why I'm looking at this and trying to figure out anything is, I don't know what data they have to suggest that 8 weeks might or might not be reasonable. So like, you know, what was the power, what were the assumptions, what sort of difference they would need to have, the number of patients to actually show the difference 8 weeks to where they may have data that shows that, hey, you know, for whatever reason, we think that 8 weeks, you know, we're gonna see 50% of the patients be better with that than sham.
Yeah,
In which case it might be
agreed.
reasonable.
Agreed. So let's come back to that. You also have
Well, I
a.
was sort of along the same lines, but here it looks like not everybody has sham, is that correct? Or do they? Because everybody gets sham.
Yeah, it does appear that not everybody gets sham stimulation from this diagram. I'm going to skip ahead just a little bit, and I'll also point out that these stimulators had 36 different modes they could operate in. And these were modes mainly dreamed up by engineers. You know, I'm an engineer, we like to add features to things, whether anybody asked for them or not. And these had a whole lot of features built in. And so they could do all kinds of different things that I've never actually seen before in neurostimulators, but, and this flowchart is quite concise with regard to the breadth of how many different things they could try out. Okay, so adaptive, my reason for saying this is adaptive is pretty wide open. Yeah, okay, so let's just, and this is the target, it was epidural cortical stimulation. Let's just skip ahead a little bit to to the results of this study. Okay, so this is Hamilton Depression Rating Scale, Montgomery-Åsberg, the Quality of Life, Enjoyment, and Satisfaction Questionnaire, and Global Assessment of Functioning. So at 8 weeks, nothing was significant. It all looks like it's kind of headed in the right direction, but the reality is nothing reached statistical significance. And so what sort of got reported in the press is that, well, this is a failed trial. Well, you can imagine as well as we can, how people interpreted that. The interpretation is this doesn't work, right? Not that it was a failed study, but again, the stakes are high, and these types of studies, whether they're positive or negative, can have a lot of indirect effects on everybody else who's working in that area, who may be doing things, a different way. So let's just take a quick look at this, and in particular, so this is a study timeline depicting the effectiveness for each patient. So black indicates remission. This darker gray is 50% improvement. Lighter gray is 40% improvement. And it's kind of a mixed bag. And I think this is, one of the earlier speakers today used the term heterogeneous, which I think is definitely what we see. So my interpretation of this, when I saw the data, was, I sort of, quote unquote, knew on some level that this was working, right? The problem was the variability. And Aniko, you should feel free to disagree with my reasoning at any time, because we've had many of these conversations. And so, on average, we had people who didn't respond at all, and we had people who had seemingly life-changing improvements. And these are patients with major depressive disorder who've been refractory to, almost everything else that's out there. And I think, this data is pretty typical of the type of data that we see, where we have just people with almost no response and people with seemingly life-changing improvements. Now, if we look at the timeline here, this is over 21 months, so this is the entire period of follow-up, and not just the original 8 weeks. And you can see that during the original 8 weeks, which would be out here, around months 1 or 2, there wasn't really a whole lot going on yet.
So even the people who had effects, that distribution isn't even the same.
You mean over time?
Over time.
Right, I would agree.
Some late.
There was also, the way this trial ended was also not great. The company went bankrupt. There was not a provision for if devices were available to study subjects after the study ended. Also, the batteries in these particular IPGs were not great and had to be replaced pretty often. I can't remember exactly, but maybe like once a year or something, once every 2 years. Okay, so then, so even the patients at the end of the study who had benefit really had, nothing to come back to. Okay, so I'm not going to go through the rest of this. This is mainly for discussion, but I'll just point out that, and this is where I want to start thinking in more detail about study design. And so this is a paper that Aniko and I wrote, because where Aniko and I were at the time, we were working together in Wisconsin, we had access to all of the data from the study. So we had access to the imaging and the outcomes and a lot of the patient characteristics. And so we did a post hoc analysis, and the purpose of the post hoc analysis was just to ask an open-ended question, just so that we as a community can learn about how to do things differently in the future. Were there things that we now know we could have done differently in this study that would have biased it towards success? And so we looked at, this is written by one of my graduate students at the time, Yagna Pathak, who is now a research scientist at Abbott in the neuromodulation division. Okay, so the first thing that we looked at was stimulation location, which is a combination of electrode location and then which electrodes were active. So this is a 2-electrode paddle. And then the other things we looked at were the stimulation mode and then also time to response. And so to do this, we used a piecewise linear model. So we had, like I said before, 104 weeks of follow-up on each subject, and then we just looked at kind of changes in settings over time and their response over time, and we looked at this with respect to Hamilton Depression Rating Scale. Okay, so one of the first things we identified was that there were some stimulation modes that were effective and others that were ineffective. So I said there were 36 stimulation modes. These were put into 3 groups. I'm going to skip ahead a little bit. The second part of this was this estimate of response probability. So this is a Kaplan-Meier survival curve. And based on the data from 104 weeks, to get to about a 50% probability, they would have had to wait for about 20 weeks. And that at the primary endpoint of 8 weeks, the probability of response was about 10%. So I've never quite understood why the primary endpoint was at 8 weeks, especially because by this time the STAR-D trials had already begun to report their data, and they said, for depression you need to wait, at least a few months. I can't remember exactly what they said, 3 to 4 months, something like that. So I don't see, other than getting a device to market, why there was a hurry, to have a primary endpoint at 8 weeks. And then the last part of this was that, location matters. And so there was a gradient where the more anterior the electrode, the active electrodes, the higher the probability of response. Okay, so this is one example. I think, like I said, part of the motivation for writing this paper was that I think we, as a community in neuromodulation, don't do a great job of learning from our mistakes, right? Negative trials often just aren't published, and if they are, then they often focus just on what the neurosurgery paper did, just saying, well, did or didn't reach primary endpoint, without really digging into the details and seeing what we could generalize from that and know to run for future trials. Okay, so I want to switch gears again and just talk for a minute about, this is a paper we published earlier this year. Let me just jump to the top. Oh yeah, go ahead.
Before you move on, you said something interesting there about having results from trials that will inform future trials, right? Now, so going back to study design in the previous paper, there's the suggestion that maybe, if it's going to take 4 months or so before you see some effect, 4 months and 6 months, then your primary endpoint needs to be there, right? Which means that someone's now on a sham for 4 to 6 months, so then the potential, the harm versus benefit curve looks a lot different for those patients. So I'm running a clinical trial which took a lot of time to get through because we do an extra surgery for brain tumor patients. Now it's a fatal brain tumor. There've been a lot of negative trials with checkpoint inhibition, but there's a lot of reasons why those trials weren't done in the right way, and maybe in the best way possible. Why maybe if we had done those trials differently up front, then we would know more about where things are right now. But I got a very tough time from the FDA because what these patients, how much is the provision of benefit? Anyway, I think that's where the bioethics thing becomes difficult for me. Is that I think when you start increasing the validity of your trial design and testing more things and taking more time and more controls and longer time in sham and that sort of thing, and then getting like that really good data that you want, then the patient harm benefit thing starts to fall down. I don't know. It's not really questions of comment. I don't know if from a bioethics standpoint you wanted to.
There's a lot of ways we could parse that out. I mean, What I'm thinking about is, well, I'm thinking about it from the researcher's point of view, the clinician's point of view, and the patient/participant's point of view. I mean, the clearest cut thing is, well, you write the grant the way that you're going to get the best data. If it gets approved and if the study, if your IRB says yes, then the patients are able to say yes or no. But are they? Are they really able to say yes or no? I mean, you can be as honest as you can. I mean, that's the right answer, right? If this is what you're going to be doing, you need to tell people what it is and why, and what the risks are. You don't necessarily need to tell them, if I had done the study design differently, it wouldn't be as bad for you. But transparency is super, super important, but that leaves aside the question of whether you can get truly uninfluenced consent from somebody in that situation, especially if you're their care provider. Do you have other thoughts?
Well, yeah, I think also, you know, especially as engineers, when we collect data from patients, we would just like to strap them into a chair for 48 hours straight and just get everything we possibly can. So there's all kinds of reasons why that's not realistic, but one of them is because people won't tolerate that. Okay, so this comes into play in I think what you're talking about. So suppose somebody consents to be in a study and it's a crossover, sham controlled, but it's a year. Are you going to lose potential participants because people say, well, I don't have another year of my life to wait until I might get benefit, and so I think this
is where empirical research comes in from the bioethics point of view. Like, we are concerned about this, but we don't know. Maybe people in that situation would say fine. If there's a chance that I could get better, maybe fine. But is there a chance that you get better? We don't know. That's what we have to do the research. And this conflict that the care providers often feel when they have this dual role with their patients is for real, and it's super difficult to navigate because you do have conflicting obligations. You have an obligation to your patient as their care provider, but you might have an obligation as the principal investigator of the study to collect the most and best data that you can. And if those two things are in direct opposition to each other, you're in this would be in a family a pickle there. And I'm not sure, as a research person, what I would say is, you know, if you're going to be doing the research, you know, and they agree to it, they can withdraw. But the protocol is such.
Yeah.
So I was wondering about how informed consent changes for risk benefit conceptualization changes in the setting of a diagnostic trial. Like I was involved in a purely diagnostic trial, which no interventional component at all. And it was tough for us to know exactly how much should we be spending an hour consenting someone for basically using some of their tissue. There's no risk to them, with the exception of exposure to PHI or something like that. And I was wondering how that affects sensitive review and how that affects study design.
Did they get, was it diagnostic testing for them, or you
For
were?
the patients. There was an experimental diagnostic test.
Did they have did they already know they had the diagnosis?
Yes.
So you weren't giving them any new health information?
And tissue would have otherwise been either sent for the permanent specimen or the garbage.
So say the question, specific question one more time.
Well, I'm just wondering about, the question of informed consent obviously needs to be done very carefully, deliberately, and be careful about not influencing people. But I was wondering if there's basically a sliding scale depending on how much risk you're exposing the patient to.
Sure, and I think the IRB will have guidance for that at each individual institution, but there are certainly exceptions, and each IRB can decide the level of risk that they think that this has to the patient population, to the study population. I don't think you as an investigator can have a sliding scale, but I do think that there are measures in place that can divide studies into categories that will have more or less IRB regulation.
So, yeah, Shai.
So, of course, I don't do these things, but the thing that's going through my mind is obviously the sample size is incredibly small.
Mm-hmm.
And it's understandable when it comes to devices, because normally they have small clinical trials. But there, it's mainly about the safety, not about the efficacy. And so looking at the design of that, clinical trial, to me, they were trying to accomplish way too much, as opposed to just focusing on safety and maybe, for an extended period of time and to see, how safe it would be. And not to have these pseudo two groups, because they're not really two groups. All they are is, in a sense, you can say one group started 8 weeks later. That's all it is, right? It's not like really a crossover study. So with all the additional analysis that you did, what's sitting in my mind is this is a tiny sample size, and you can get whatever you want, basically, And so I don't know how to read these results, and certainly I wouldn't talk about a trend, because there's really no such thing as a trend. That's the definition of p-hack. If you assume I'll add 2 more and everything will hit that thing,
Right.
where you're fine. So that kind of turning it to you, back to you. How do you? Was it worthwhile doing all that additional analysis on 11 patients?
Well, as a researcher, definitely, because we were able to do statistical testing on the data, which admittedly was post hoc, right? So we're very open about it. But when we're doing this type of analysis, we're generating new testable predictions about what can be done in the future. So this isn't just, maybe it's a trend, and it's certainly small numbers, but this is what we have to go on in early stages. And this, I wanted to say this before also, and then I want to turn it over to Aniko about the kind of a better way to think about the statistics. But often for these surgical studies, because they're so expensive and they're invasive, the patient numbers are small, right? Even if you're allowed to go above the 500K limit per year, we have UH3 right now, and that we were budgeted to implant 60 brain stimulation patients over 5 years. And as researchers, I'm thinking, oh my gosh, we have to make every single patient count. We cannot lose like a scrap of data. And I think we also know that even though, yes, that is a very small study, that whatever the outcome is probably going to influence future research in that area. And so we do have to be really careful and diligent about it. I don't know, Aniko, what do you think about just sort of this class of studies where you have relatively small numbers of subjects?
Well, so I actually think there's a big intersect here with ethics and the sample size. So if you run a study that is too small to give an answer, then you you lost the benefits. You might have potentially benefited some individual patients, but you certainly lost the societal benefit aspects because you didn't generate information. You don't know the answer to the question still.
I would add to that it's unethical.
Yes, that's exactly, yes. That's a completely ethical issue that you just lost the benefits, all the potential benefits that you promised the patients, right, who participated in the study. You promised them and they are not, that benefit is certainly completely lost but it is a major, difficult statistical issue, and I think we will try to do some experiments with it, but it is difficult to get good results out of small data sets, because in statistics, the way, as Chris was pointing, there's lots of variability, and the only way to go around variability is to get more samples. That's the only way statistics works, right? You need lots of more data.
Or a greater signal. So it might be, maybe 8 weeks is not enough. You have to do longer, which you have a greater signal.
Yes.
And judging from the timeline of the various patients, it started, the so-called benefit started at different times post.
And I think in that particular trial, the adaptive stage was actually really powerful to actually getting the benefit once they started tinkering with the settings to find the right settings and whatever. And that takes time.
But then why did it drop? because they changed them again?
What do you mean by?
You mean effectiveness was not consistent over time, even in responders?
Once you had the responders, then towards the later times, it dropped back down. So is that because they were tweaking the conditions, or?
Well, we don't know. There were, like I said, there were a lot of problems with the devices, so there were also device failures.
I
So
see.
we can't, I mean, we couldn't rule that out either. But Aniko, maybe you could just talk, just for a few minutes, just number one, I mean, I think we've all been exposed to power analysis, but just maybe a short refresher on power analysis, as we're sort of like dancing around it right now. And then just conceptually how you can, using synthetic data and simulation, sort of like turn that on its head and inform it.
Okay, I should do it at a different point as an exercise. Okay.
Maybe just sort of set it up and just explain it, because I think we're headed in that direction right now.
All right. So. No, I don't think so. So with the one of the part of the study design, right, is to decide on the sample size, and the major issue with the sample size design calculation is that you need to unfortunately figure out ahead of time lots of things that you don't know when you're designing the study. Right, so I don't know how many of you want to talk to a statistician when designing your studies, and you should to do that before, right, when you are designing the studies. But they will always start asking questions about, so how many, what kind of difference do you expect, what kind of variability do you expect, and so on. And especially as the study gets complicated, it is difficult to get all that information. So the idea of the sample size calculation, the basic idea is that we want to design a study so that if you run it, you will get a statistically significant result, right? And whenever if you run the same study several times, it turns out you actually get widely variable results. So you could run exactly the same study on exactly the same, not exactly the same patients probably, right? But the exactly same patient population, suppose and everything. But if you run, you will get, sometimes you get a p-value of 0.26. Next time you run it, you'll get a p-value of 0.5. Next time you run it, you get yet another p-value. You can get really different results, right? So we try to get the sample size that most of the time you would get a result, a p-value that's less than 0.05, right? So that's what we are going with the powers, that if you run the study 100 times, then 80% power means that 80% of the time you should have a really small p-value. But so unfortunately, of course, it doesn't guarantee it. So even if you powered your study at 80% and you still have, and your assumptions are correct, you still very happily could have a study that has a p-value of 0.5. There is nothing that things happen, unfortunately. So one of the things we do with the power calculation is to try to simulate many possible studies. Right? So we'll try to set up, and this way we can do more complicated analysis on the study and still try to see what kind of potential results. So I think have set up something. Well, switch it around. So let's see. So I try to have, so I'm running some fake study, okay? So I have, oh, they're not seeing me.
Just give it a second. No, it's right here.
try to get it bigger. Okay. So this is, for example, one study, and ignore the color, I think. So we have measured some value after 6 months. Okay, so this is our control group, this is our intervention group, very simple setting, okay? And you can kind of see this looks promising. If I run, right, so intervention is, so suppose lower is better, okay? Intervention is low, looks lower. And actually I have, I think, yeah, I ran a t-test on it. P-value really, really nice. Okay, so we have a significant result. Then I did it. So this is data that was simulated under some settings. Okay, so I did run the same simulation with the same sample sizes many times, 100 times. Okay, and this is what I get. So this is all the p-values that I got from 100 runs of the same thing. You can see actually my power was 31%. That was this red bar when the p-value was under 0.05. But you can see that exactly the same. So that first one happened to be just a lucky one, just one of those 31s. But I got p-values like all over the place, right? So you can really get, again, this was not a very powerful study, but 30% power is not, yeah, I could be lucky, well, third of the time, right? So if 3 of you go out and run that study, 1 of you will be lucky, right? And will report a major result. I mean, and they were correct because there was actual difference in the things I simulated. Somewhere I have a, okay, so this study had a, okay, let me show one that, okay, this one had a 86% power. Okay, so that's a really respectable power. It's a different setting, but still. You still have quite often like p-values even like 0.3, 0.2, right? So you can have really big p-values even though you have pretty respectable power to do the study. So that's actually one thing that people often like start to, right? A misconception that if it's, okay, maybe 0.05 is significant, right? 0.1, I know there is no such thing as trend to significance, but it looks like promising. But something like 0.2, 0.3, you know, really doesn't look promising at all. And that's not true, okay? So really at the p-value, you cannot just tell, you know, high p-value doesn't mean that there wasn't action. In fact, it's not promising, you really just don't know from the p-value itself at all what's happened. But that's one way we get to, you know, set up the data and the example, try to generate data from what we think could be happening, and then we'll see the power, you know, and we can manipulate things in that, right? Like how big a sample size is, how can I manipulate the design, how I can do things, and try to see what the results are.
So I think this is a powerful approach, and it's a tool, and it's not a really exotic tool, right? It's one that many people could do, you know, with the help of a statistician, or maybe do by yourself. But I think the point of it is that virtually all of us who are writing a research grant have gotten to the point where we have to do a power analysis, and we have to estimate things like effect size and you know, variability. And it's often just a maddening exercise, you know, and I often have a thought, I have no idea, that's why I'm doing this study. So this is a numerical way to turn that problem on its head. And if I make a range of educated guesses about what could happen, what's the overall probability of having a successful trial for assuming that the intervention actually works. Yeah?
So I get all this in clinical trials and the DBS example you mentioned, and even the brain tumor patients that someone brought up. But what about when we get as far down as things like mice and dogs? You know, I think I've seen reviews where they said you haven't run statistical analysis for your primary endpoint on your mice to get a power to 80%, and then looking at, and I got basically what I would expect to see in a phase 2 clinical trial. I got the same critique for mice I'm trying to test on an intervention, or to get a signal of some kind with the variable. In study section, how important is that? I mean, because I keep, in some things it's never commented on, but I've seen in others that, I feel like I'm going to be up in front of the Nuremberg group in a second.
So I think it's getting way more common that this idea that you need to justify your sample size is trickling down, right? It was really, people were looking not only for humans, now they are looking it for animals as well.
Sure.
So you really need to do.
So does that
and the
mean
sample size calculation is actually really the same. I don't care what those numbers are really, like, the math will be the same, right? Whether it's
you're right, but
yeah.
Do we have to apply those assumptions and the set signal, whether it's a 30% reduction in tumor size or that much more motor activity, and given in someone like me, I care about reduction in stroke volume or even improvement in
So usually the good thing about animals is that they have less variability. So usually that, and maybe bigger effects, because you really can do exactly what you want to do, unlike in humans.
Do I need someone like you in my group to say, hey, we have a statistician that for the mice has this, and therefore it's valid? Because at our institution now, biostatisticians aren't free. So we have to pay for every biostatistical model.
You are asking me, right? I'll tell you, it's a wonderful investment.
I'm at a public institution.
No, but it actually is a good investment. I work on a lot of basic science grants, and people are more and more coming because study sections are looking out for it more and more and more. Like, they don't necessarily need as much effort from me as a clinical trial does.
Yeah.
But they absolutely, it's good to talk with them, and if you need to pay for 2 hours, it will be time well, money well spent.
One other option is you can list them on the grant in some capacity, depending on how much you anticipate that you may need that help. So they can help you with the staff for the grant and power analyses, and you don't necessarily need to pay them up front, but then
You get it back.
Right.
You get it. That makes sense.
So, also, I'll just say, just a bit of history here. I mean, when Aniko, when she introduced herself, she said she runs the statistical consulting service at Medical College of Wisconsin. You've run it for 20 years. And I think that's actually how we met the first time. And then over time, when I was submitting grants, we would have a conversation about, like, kind of budget or time, and what would be kind of appropriate for the amount of work that we anticipate. I'll just say this is not incredibly expensive. It's not something that takes this huge chunk out of your grant budget, and the dividends are huge. I guess the other thing about it, a practical constraint, since you brought up study section, is the reality is for a 12-page approach section, you can afford about half a page for your entire statistical plan. If it gets much longer than that, you're taking a bite out of your research part of it, like the procedures you're going to do, and that's a huge challenge. Getting a really complex statistical plan into half a page and making it believable. I agree. And study sections, somebody said, have different personalities. That's absolutely true. They have different things that they'll look for, and so I think it sort of depends on who's reviewing it as well. Yeah, Shai, did you want to say something before?
I want to say a couple things. One thing I'm waiting for to open, but Aniko, you're very special. And I say that because the majority of biostatisticians are experts in how to run clinical trials and have no clue what to do with animal studies. And the reason is that, with the exception of like neurosurgery, which is, or devices in general, which is very small samples, randomized clinical trials is a huge number of patients. It's a very different kind of ballpark. And when you come to talk to them about, I'm going to have 10 samples per group and so on, they really don't know how to give advice. And I see that, across the whole nation. Very few biostatisticians that understand preclinical research. So so going to the statistician that is an expert in doing randomized clinical trials in your institution might not be of much value, okay? That's, but the other thing I wanted to say, and I think Aniko, you said this very well, describing how to calculate the p-value, but I think an important element might have gotten lost. And I want to read the quote. That's why I'm opening it. Excuse me for a second here. Okay. So, what Aniko said is basically when you talk about the power, it's if you do the experiment 100 times, how many times you would expect to get the right, a significant result. So what that really means is that for any given one experiment, I mean, it's meaningless, okay? What you get is actually meaningless. And I want to read you the quote from where this power calculation came from, which is from Neyman and Pearson hypothesis. And what they wrote is the following. No test based upon a theory of probability can by itself provide any valuable evidence of the truth or falsehood of the hypothesis. But we may look at the purpose of tests from another viewpoint. Without hoping to know whether each separate hypothesis is true or false, we may search for rules to govern our behavior with regard to them, in following which we ensure that in the long run of experience, we shall not often be wrong. Okay? That's what they meant by this. Okay? Now, the scientific community made a mess of this, but it's really not about any given experiment. So even though we say we've got to do sample size calculations and to calculate the power and so on, it's on some level, and I'm being recorded here. It's a game that the scientific community developed because you said very clearly. You can get a P of 0.3, and it would actually be there's really something there, but you don't know. And you can get a 0.01, and it's absolutely meaningless. So what's the value in that? And that's why yesterday, when I gave my talk, I showed you that paper that people are saying, let's get rid of statistical significance. Let's look at effect sizes. Let's do Bayesian statistics, so we look at what's the probability that this result is actually meaningful.
I guess the difficulty for an investigator, though, so for my clinical trial, I had a similar experience to what you were talking about. So again, same thing. We're looking for interferon gamma to go up in cytokines and microdialysis catheters and brain tumor patients, okay? And there's been a couple trials that show what interferon gamma looks like after surgery with these microdialysis catheters, and it starts at a number and it goes down to some other number. The numbers are really only valuable in comparison to another number from the same catheter. So, I think interferon gamma is going to go up. Okay, by how much? What number are you looking for? I have no freaking clue. None whatsoever. You got to give me a number. I don't have a number, but you got to give me a number. We're doing 10 patients. We're looking at safety and whether the data looks relatively reliable, so we can extrapolate this to more trials. But you have to give me a number so we can do the power analysis. So I come up with some numbers and we do the power analysis. It goes in the protocol, and it went through. And everyone loves the power analysis. It's like, it's great. It's like, yeah, it's like, oh yeah, it's gonna go to 0.4. Oh, fantastic. That's a great number. I love that number. I mean, it's kind of.
Somebody's gonna cite that number now.
I know. Like that's the target for cytokine microdialysis trials. But if you don't play the game, so if you submit a grant, which I did a few weeks ago for this, and you don't put a power analysis in there because you're doing something fairly exploratory, and you don't know, and so you figure, well, hey, no one knows. You don't know what the law non-coding RNA distribution is going to be for these various patients. But then you'll come back and go, so why'd you pick this number of patients? Well, it's very expensive, and it's the number of patients. I feel like you have to play the game. Like if you don't play the power game, then you get criticism for not playing the game.
So it doesn't necessarily have to be the power. It's really exploratory, right? So there are two ways around it. So for real there's been some work. If you're really doing an exploratory study, and you are planning to do a big study, So there's some papers out try to say balance the size of the preliminary study and the final big study to trace how much should I invest into my initial study to get good estimates so I'll do the right big study later on. And so they try to get sample size calculations based on that. And that actually tends to return numbers in the 10 to 20 range, so it's a really nice kind of power. It depends on, also depends on some inputs. At some point you have to guess how effective, but so there are some, tricks like that, or there are sometimes ideas that you would instead power, do the sample size if you want, on the precision of your estimate. I want to find out how big the difference is, but how precisely do I want to know? Within 5%, within 10%, whatever. Based on that, that goes away from the p-values. But at least it's not good for comparisons. But if you just want to have some estimates that later I will be using, that can be something. Again, tends to have somewhat lower sample size. But the other is to come up with the effect size. You usually, of course, you don't know what's going to happen in your trial because nobody else did it, but you often have some idea what differences have been seen with other in that same thing in another group of patient subjects, right? And for another indication, for if nobody ever measured that thing, you should measure a little bit before it. So what is, if something changes, something is kind of varies, then if it changes, the change is very little with respect to that variability, probably it's not going to be highly clinically significant. So you can try to figure out, right? So you are making informed guesses for power calculation. So what difference would need to be true for me to start thinking that it actually could have an impact somewhere down the line? Because if something just changes, but it doesn't matter, then nobody cares, right? So how big the change would have to be for somebody to start, for it to have effect that actually somebody cares about.
So let's this is great discussion. Let's shift gears a little bit. I want to continue talking about these things, but also in the context of an example, we can show some more data that's acquired from studies that we and other people have done to characterize these the magnitude of these sources of variability. So we recently published this retrospective paper on deep brain stimulation for Tourette syndrome. And this is mostly open label data. There's, I think, 185 subjects worldwide who've been implanted. And off-label, there were a few trials that were done, but they were relatively small. So just out of curiosity, who would consider this? Who would consider trying DBS for a Tourette syndrome patient? A few people. Great. And so I would estimate 9 or 10 people. And the rest, I take it, are sort of skeptics. So why don't we try an exercise where the people who raised their hands, they can be the grant writers, and the people who didn't raise their hands, they can be the reviewers, and we can propose ideas about how to design a study that would test this, and then hear what the reviewers have to say about it, and maybe refine it. So who follows? And I'll structure this a little bit more. But who follows DBS for Tourette syndrome? Well, okay. So among the patients worldwide who've been implanted, there have been many different targets tried: nucleus accumbens, anterior limb of the internal capsule, interior segment of globus pallidus, central median nucleus of the thalamus, and I think there are one or two others. The majority of them have been in pallidum and in thalamus. And so if we were, for the people who raised their hand, just the simplest possible study design, I think that we agree that, especially when you're writing grants, simplicity wins. If you want something the reviewers can understand and get enthusiastic about in 12+1 pages, it has to be concise and clear and just as simple as you can make it. So what's the simplest study design you could imagine for testing this?
It seems like you could randomize patients to, I don't, background, I don't do anything in functional, so.
That's okay.
But I imagine you could pretty simplistically randomize patients to on and off periods, so each patient could serve as their own control, and then you can also compare it to other patients at different time points. So one person would start with an on and then be off, etc. You could then compare it to.
Okay, so you would pick a target and, you know, one nucleus, just whichever one is, you know, the most, has the best justification. And you would enroll some number of patients at one site or at multiple sites?
Multi-center would be ideal given how few, you know, how many few patients have been reported and how difficult it is to enroll patients.
So I think I heard one site and I also heard multi-sites.
To keep it simple,
To keep it simple, keep it to one site, and how would keeping it to one site reduce variability?
surgeon and raters.
Same surgeon and same raters. You know, you might run into, I mean, how many Tourette patients are severe enough they would consider DBS? And okay, so that's just sort of an open question, but it's probably not a huge number. So there's sort of a trade-off in enrollment. Okay, so maybe, okay, but then you also brought up something important, and that was patients being their own controls. Because what's the alternative to that? I mean, so you brought up I believe you brought up a study where everybody's implanted, everybody gets surgery, there's no sham surgery. We don't pretend to put in a DBS lead and expose them to the risk with no possible benefit, right? Everybody gets implanted, they're turned on or off at different time periods. Okay, so how, so maybe, you know, one part of that, Aniko, is, you know, how would you think about you know, within versus between subjects? Do you want me to switch it over?
No. So in general, yes, you're right. So within subject tends to be much more powerful because you can eliminate the variability of between subjects. It's, on the other hand, the weaknesses, so that helps if things are more stable within patients than between patients, which is not always true. I mean, you can imagine things where it is not the case, that that things are more constant within patients. But the requirements for that is that you can actually do it. So there are not, in practice, not that many situations where you can do it, because suppose I start with the intervention part, right? And then I, you know, with the on, and then I turn it off, right? So did my effect wear off, right? So how long does it take for it to wear off? Now, as far as I understand DBS, maybe it does wear off, right, after some time, and especially, but if you think that it takes some time, like in depression, right, to start acting, then it probably takes some time to stop acting, I don't know, right? So, but you have to start having big issues that this having washout period to make sure that you actually are comparing to not having the subject, right? So, especially on periods, off period, if you really have to keep switching, you really think that it wears off pretty quickly. So you probably won't.
So in that case, could you enlarge your sample size? Well, it's Tourette's, it's rare, but they would be randomized to which came first, which stimulation condition came first, so that you could.
Yeah, you certainly, yeah, so that is a very, so that's a very good point, that if you are going to do a within patient comparison, within subject comparison, just doing it by just always starting with the say sham, and then the intervention would be relatively weak design, even though then you at least avoided the washout, right? But on the other hand, you are, maybe during those, I don't know how long you want to keep it on, right? But during that time, the patient deteriorated, right? Or maybe, so you would want to randomize the order, but that doesn't help you with the washout issue.
I mean, how many patients does the average center see like this in a year? I mean, I just don't foresee that you get more than a handful of patients per year that you can do a single institutional study. And then the second thing just about that order is you've got to have some patients that are on first and some patients that are off first, because, I mean, again, this is in my area, but I imagine just putting the electrode in could have some effect, some real effect, and also some placebo effect. So then you've got to, and then as far as the washout, one last thing would be, you've got to have a long enough period to allow all that to wash out. So maybe, I have no idea, but I got to imagine you've got to be on for 3 months and off for 3 months, or maybe it's 6 months.
Yeah, that's all true. I just thought that's kind of the issues you have to think about, right?
Yeah, and then I guess my question, and this is just a statistical question, is, so if you wanted to do an analysis of an inter-patient and an inter-patient analysis, and then maybe you decide you want to do some sort of multivariate analysis to control for characteristics within, so I assume you're talking about some sort of generalized estimating equations or some other analysis like that. How many patients do you think you would need for something like that?
What's your effect size?
I can totally, right, yeah. That's,
I would imagine it's going to be a pretty reasonable number, though, I guess is what.
so it really depends, right? How big you think is this DBS going to be with the patients?
So there's also a curious situation that's happened where in the crossover design that you were talking about, that we've had patients who were turned on and then said, you can't ever turn this off again. So sort of, I don't know what it means to withdraw consent at that point, but.
Can they definitively tell if they're randomized? I mean, if the effect size is huge, there's going to be some patients that know it's on.
So one funny thing about these neurostimulators, across the board, across indications, patients usually know, one way or another, they figure out when it's on, when it's off, what arm of the study they were in. I mean, this is, we now will put this into our study design. At X time point, usually down the road a bit, we ask them, what arm of the study do you think you were in? And I think they're usually right. So the blinding in itself is, with the patients, is a bit of an issue.
I have one question about just back to the power because you brought up. Can you factor in effect size to the power analysis? I mean, I thought you could just run power analyses for 10% effect, 30% difference. Can't you just include that in your simulation? Like, what if I were to see a 30% change?
Well, yeah, that's exactly, yeah. So you
if
can,
he said he has to have a number, you don't have to have a number.
You have to have some numbers, and the answer will be different, right?
Sure, yeah.
So in that sense, you have to have at some point you need to have a number.
So
when you're presenting it, you might present, okay, this is our number, and this is how the sample size of the power changes as we change this number, but you have to settle on something.
The problem is if you're starting at 0,
yeah,
then you can't have a 50% increase, or 100% increase, or 30% increase, or 20%
Oh, I see.
increase. You have to have on off at some point. That's the number that you, which is, doesn't matter.
And there's no, I see. But you don't know, like, I see. You never had like a number, like what you said, the previous study. You didn't know, like, at least you'd have a range, because that's where you could come up with 50%. You just need to know the max.
In theory. But again, after a biopsy, no one's put in a microanalysis catheter, waited 2 days after the biopsy, and then looked at it for every that's including less than patients were recurring.
So, Chris, to the best of my knowledge, PBS, it's not a binary. It's not on/off.
True. Yes.
So that hasn't been discussed here yet, right?
And that's a whole other dimension. Yeah. So let's talk about that a little bit.
So, but that's the dimension where you can introduce differences between groups and increase the likelihood for blinding, because they won't know when it's at 10 hertz or at 50 hertz. You know, they just don't know, I feel something, I don't feel something, right? So it's a way to actually increase blinding.
Yes, so we don't have a well-developed concept of a dose for neurostimulation, but as a surrogate for dose might just be stimulation amplitude. You know, how high did you turn it up? But let's get into that a little bit. So here, Andrew has some of the data that's in this recent publication. And so is this grouped by site? So just go ahead and turn on one site. Doesn't really matter so much which one. Okay, and so these were, and so what we're looking at is these are individual DBS electrodes, each lead. These were mostly, but not all, Medtronic, so these were 4 contact leads. And so these are the lead locations. All the patients were bilateral, 1 lead in each hemisphere. Some of them had 2 leads in each hemisphere, but not many. And the leads are straight. The reason why some of these don't look perfectly straight is because of the nonlinear registration methods when these electrode locations are mapped into Atlas space. So go ahead and turn on another one. And if it's, okay, so the green, these are all from one site? Okay. And then what if we just zoom into thalamus? And you have here, I assume the labels are the same as they are in the paper for the thalamic nuclei.
Yes.
So blue, go ahead.
You have CMPF and you have ventrolalis internus, control ventrolalis internus. Right, so CMPF is here in blue, which is usually listed as the primary target. But even that can differ between surgeons.
So, yeah, so CM was ostensibly the target for many of these patients. So if you turn off the blue site for the moment and just look at the green, and then look at and maybe, can you rotate it a little bit just so we can get a better sense of the distribution in terms of, like, you know, superior, inferior. Okay, so this was, you know, this is a single site where leads were implanted, and I would say, having seen imaging from thousands of these patients, that this is a sort of a normal distribution of locations. Yes, these are all expressed in Atlas space, and you know, one of the first objections that we always hear is something went wrong in the registration process, that somehow amplified this distribution. The size of the distribution, just believe me when I tell you that's not true. We've done this many, many different ways, and ultimately the way that we convince people that it's true is we show patients back to the clinicians, and we show it to them in patient space and then in Atlas space, and they can just do a direct comparison of the two. Anyway, so I think this is, and maybe zoom out a little bit because I'm even getting lost, and then just rotate slowly so I can get so we can get oriented. Okay. So just again, looking at the thalamic target for one site, I would say this is a very representative distribution. And what happens if you start turning on other sites that have?
I'm sorry. When you say site, what do you mean? A target or?
Oh, sorry, I'm not being very specific. So I'll be more specific and precise in my language. So by site, I mean DBS center.
Okay.
So a different institution.
I have no idea what these dots represent.
So these dots represent individual electrodes on deep brain stimulation leads.
So you mean a quadripolar lead? Is that what you mean?
Yes.
So these are contacts.
Yes.
How many leads were implanted, say, on one side? Because it's still very. This may not normally use the.
Yeah. No.
A lot of trouble.
I'm glad that you stopped me.
So how many leads were in one side?
Generally one.
I'm sorry?
Generally one lead per hemisphere in each subject.
I apologize, what I meant is how many leads am I looking at?
Oh, I see. Do you know? We can quickly estimate by,
Number of bets divided by 4.
yes.
I still don't understand where all these leads are being placed to begin with. Some look like they're dead, like caudate nucleus or
I
something.
think that's the problem.
Pick a small site. Right, there's about four implants. So this site implanted 4 patients. Is that essentially GPI or is that's not as a GPI?
Was the target intended to be the same?
Yeah, I'm curious if maybe.
That's gotta be
just
GPI.
just-
Yes.
Yeah,
just
okay.
simplify.
So that was pretty good.
But you can't compare.
That's not good. That's not good. That's not good at all.
Compared to the green ones?
Well, that's okay, then.
Yeah, that's pretty.
You know, the other thing that perhaps would help with the clearish structure is the body of the thalamus, right? Are you able to delete that just for a second? Just so we can see, there's just a lot going on.
Mm-hmm.
Okay, that would help.
Do you know where the active, do you have data for just the active contacts?
Yeah.
As opposed to.
Really.
Yeah, we do. Here, I have this figure up. I'll just switch it over and just show the just the active contact locations. So this is a figure from the paper, and so this is maybe a little easier to understand because these is only active electrode contacts and they're color coded by the surgical target. So, and I think, and we've looked at this particular data and this type of data for many subjects. So I think that in general in the surgical literature, it's reported that the accuracy of stereotactic surgery is 1 to 2 millimeters. And there's a variety of other things that can come into that as well. Brain shift, which is a bit still inconclusive, but almost certainly causes some change in bilateral same-day surgery on the second side. And there's other factors that come into play, but all of that is to say that I think this is representative of what we see for DBS electrode locations. Okay.
I guess just one quick impression. I don't know anything about this study whatsoever, but if this is the normal distribution of DBS leads that have been attempted to be implanted in a single site, but distributed over multiple sites, DBS centers, I mean, it would make sense that you would get a heterogeneous result because these do not look like they're anywhere close to the the same place.
There's confusion. Multiple centers have their own.
No, I'm saying even for the same target, they don't look. I mean, like if all your SDF patients look like that, they were just all like far apart like that, right? And that's not how we look.
Well, for example, the GPI,
There's no
the
estimate.
yellows are breast or, yeah, like, yeah, and from immediately.
Okay, but I can tell you, I've looked at hundreds, if not thousands, of STM DBS patients as well. Distribution is exactly the same. There's nothing unusual about this.
So you're trying to show that it's not.
So this is, so I guess, part of the point of this is that the surgical target is usually described based on a nucleus. And people have all different thoughts about that, right? So one just observation from this, if that nucleus is GPI, well, that's a decent sized volume, and there's you have a lot of decision-making space within that. So that's one, and these are all just natural ways that variability is coming into these types of surgical studies. And so part of the reason for showing this is just to illustrate that if you're if you're a study, let's suppose the study design is CM stimulation for Tourette syndrome, that the targeting could be different in ways that I think you're describing. And this is just the starting point. This is before anybody's been turned on yet. And then I think the other thing that you might see if I switch it back to Andrew, and I think somebody mentioned this a minute ago, that different surgeons or different centers might have a little bit different approaches on how to do this. And I think that we probably agree that these types of complex surgical cases, there's many small decisions that are made end to end in how a treatment plan is put together for a patient. And some of those are just sort of the way that an individual center operates. And so these aren't things that you would necessarily document in a manuscript or in a grant, but these things can affect the way that it's executed. So if you start turning on the other sites, then I think centers, and we begin to see that, to some degree, data can be clustered a little bit by centers. Okay, so this is one kind of source of variability for these types of studies. If we were to, again, continuing with this exercise and just thinking about if we were going to design this study, what would be what do you think would be a good primary endpoint? Let me put it this way, how long would you wait for a primary endpoint? A year. Okay, and so, do you want to switch over to yours? Or not yet?
Okay, so are we doing within patient crossover and 1 year for each? So we are doing the within patient crossover and 1 year for each setting?
You mean okay, you're comparing the study.
Or we are, yeah.
Oh, 6 months with crossover, yeah. So I didn't hear you.
So how many patients you think will be there at the end of the study?
I mean, you're asking about the dropout rate?
Because I think the longer you wait, right, the more, and not just because patients do something, but because the lead gets infected and has to be removed or whatever, things happen, right? So it doesn't mean that somebody is being uncooperative or something like that.
I would estimate 5% dropout. I think most of the other studies have shown that at a year, patients will still be.
Okay, so sorry, I had set up a little simulation for this to try to run different designs. So we have 6 months. How many patients? Right?
How many?
Yeah, so how many sites can we recruit for this study?
Can we back up just a second?
Yeah.
Yeah, because at least I don't do this stuff, and I think not many here do DBS.
Yeah.
How long does it take to, from other fields like, Parkinson's disease, you implant it, how long do you have to wait till kind of everything settles down and you start seeing effect? Something from a different field that the group here can get a sense of what decisions they're making.
Sure. No, that's a great question. So the response time to neuromodulation in general ranges from seconds to months, meaning over a year. Tourette syndrome is probably on the long side of that. So in the paper that came out earlier this year, the median response time was 13 months.
Well, that's good to know. that application, NIH grants are 5 years by definition. And you're not going to obviously not going to recruit everyone in the first year. It doesn't work that way. So unless you increase the number of sites significantly, so you can get almost everyone recruited in the first year, so you can follow them throughout the 5-year study. So that has to be taken into consideration when you're doing your calculations here on how many sites you're recommending, et cetera.
Sure, absolutely.
So here I tried, again, I have set it up so you can just run some scenarios. And I used it's not the actual data that was from the paper, but I set up a simulation inspired by that data. Okay, so I tried to approximate it so we have more flexibility into trying different design. So this one, so first, okay, so 50, I had put 15 subject, 5 sites. So would you put 3 subject per site or?
Well, I think, for something that's rare like this, you just start with the number of patients you need to get your desired results, and then determine which centers have those patients. Some DBS centers are heavily involved in psychiatry, and some are less so. So ideally, it would be the center that have the most patients, but I don't know how many.
Yeah. So. Okay, so this is an example then. Okay, so this just one study, and this was actually pretty good design. We got 80% power. Okay.
This was waiting how long?
This was waiting 6 months.
Okay.
Yeah, waiting 6 months was again based on the data we had was already enough, even though not everybody's having response. So this tries to show the control and the intervention. I didn't, within the same patient, right? So you see actually some patients didn't really respond, right? Their intervention scores are higher, but some patients respond, and this overall was already kind of fine. If we add some dropout, I had a bit bigger dropout. Then it is already not quite enough. It was 63% power. There are always more dropouts than people think. I think because things happen, not just because patients don't comply, but because things happen beyond control.
So the data from the paper and Aniko made some permutations of that data, so I think it's very representative. This is a retrospective study that of about 120 cases worldwide out of 180 plus or 200 that have been implanted total. And I would say in this paper, mostly what was done was a description of what has been done, where stimulation settings that have been tried, the areas of the brain that were modulated, and because it was a retrospective study, it was just, it was a sample of convenience. But also, I would say, as a researcher and as a grant writer, being somebody who is just pathologically optimistic about the types of interventions that we do, this is an example of something that I believe works. Can we, justify doing another clinical trial and using this type of data to power it so that we would have a high likelihood of having a positive result? And so the exercise here is to just try to illustrate some of the decisions involved in that process and a little bit different way to look at it than just going to a power calculator and just plugging something in and just running it once. Any other permutations that people want to try? Yeah, Shai.
I want to comment on the previous comment. No one raised their hand. So you said 130 something, basically, cases, right?
Yes.
Have you stratified them based on the location of the electrodes to see whether there's preferred? Obviously, it's retrospective, so you can't, it won't you can't report this as a major finding. But to steer the next study, to say, oh, if we make sure that the electrodes are in this location, we see a greater fraction of patients that respond as opposed to other locations, and then propose to do a trial that focuses specifically on those areas.
Yes. So this paper that I showed you asked that question. And location alone was not a good predictor of outcome.
Wow.
There is a second paper that was submitted less than 24 hours ago that looks at other types of predictors that appear to be much, much stronger. Strong enough, in fact, that so that's just going into review, so all right, we'll see what happens. But if that pans out, that paper actually has testable predictions in it, so that it could be the foundation of a future trial. But asking the question that you asked, which is a very natural first question to ask, that alone was not a good predictor of outcome. So I think, yes, just in general, the field of neuromodulation is, in their thinking, they're moving away from nuclei and more thinking about circuits. And circuits can be quite different between people. And the biggest normative data I think we have on that now is the human connectome. So you can, there's I think over 1,000 patients now who've had high quality structural and diffusion-weighted MRI. And if you look at that, especially if you look at the diffusion-weighted MRI and you run tractography on it, in areas of the brain that are pretty well defined, that's where we see this variability in what I'm calling circuits. So these are mostly information transmitted via large white matter pathways. And that degree of variability is in some ways independent from just morphological anatomical differences between subjects.
I have another also potential comment on this because I think it's often a difficulty here, is that when we are talking about just whether DBS works or not, you are comparing it to not having any DBS, right? So that if it is working, suppose it is, that's a relatively big effect compared to, suppose DBS works somewhat better with this location versus that location. Like, what's the effect, would you be expected, no DBS versus DBS, how big a difference would there be versus if you have just two different target locations within the brain, right? So maybe the difference would be half as much, okay? So like even then, like I'm already, right, saying that there's a pretty decent difference. So if the difference is half as much, you need 4 times as many patients to have the same power, to have the same precision for the estimate. So you need way more patients always. So as soon as you start asking like fine patient, oh, did this version matter versus that version matter, your effect sizes shrink a lot. So that's why I think the other issue is certainly it might not matter, right? As a matter of fact, it might not matter, especially, right? But it also is that just because your data is enough to show that there is an effect, it's probably not enough to show that where the delineations. And that's also where often people go wrong, is saying, well, there is no significant difference, so it doesn't matter, right? And look, the p-value is 0.5. Well, again, it very well could matter. It just you were nowhere near enough.
Okay, so we've been at this for about 2 hours, and I'm detecting that energy level in the room might not have another hour in us. So, and this is sort of open-ended, and we came here with a lot of different types of data, just sort of illustrate not just the factors that go into thinking about study design, but also some of the tools that we can bring to bear on it in terms of numerical simulations. I didn't talk at all about modeling and simulation and other types of synthetic data, image data, and we use this in my lab, and certainly plenty of other people do as well, to try to really, hone this down into testable predictions. When there's many areas of medicine, and this is one of them, we don't have a really good mechanistic understanding. And so because of that, we have to use other clever ways to kind of work around what we're doing and constrain it and to come up with predictors. So I'm happy to continue having sort of an open-ended discussion where we can just kind of break for the day and just have informal discussion. I'm happy to talk with anyone afterwards, and as Aniko as well, Andrew. Before we break, any other questions on what we've gone over?
I have a question.
Oh yeah.
So what you were doing here, we were kind of trying different simulations with different variables about different effect sizes and things like that. I guess my question is how that goes in the study sections when you see those things. So for instance, if you were just replicating a study, you know that this was the effect size that they saw, this is the number I'm going to need of subjects to reach a statistical level of significance. You have one number that's going to replicate that exact study, but usually that's not the case. Usually something like what you described, where yours isn't anywhere near what something else is published out there, but you're maybe sampling a few other things that are somewhat close. And so you get a few different numbers that are close. And so you get a few different numbers of what you might expect, right? So can you put that in your grant to say something like, of the things, of the 5 or 6 studies I saw that were close, here were the effect sizes. And when we went through the power analysis, it was somewhere between 10 and 10,000 patients that I need for my study, or something more narrow. Does that fly when you say I need somewhere between 100 and 200, or whatever the number might be? That because otherwise, to say it's one number for my one study goes back to what Shai was mentioning, is that's not the way the statistics work, right?
And also budgeting becomes a pain in the butt, because you got to budget, especially if you're doing animals or humans, then you got to have a budget justification. I've been through all this, that's why I'm opinionated. That it becomes difficult.
I can tell you what I did in that scenario is I did not give them a bunch of variables personally, because I knew they wouldn't have read the literature as much as I did, and I did. I read everything that had been published in trauma and brain tumors and whatever, try and get some reasonable number, and then I put it together. I cited the papers that had been done, and I gave them my best guess, and that was fine.
So you gave your best guess,
which was a synthesis of all the data that I.
And you felt that's a better option than saying,
I don't know.
Here's the range of what I found, what I would expect.
I would agree. Yeah.
I think it's perfectly fine to justify your best guess by saying this is the range I found, so thus my best guess is this. But power calculations are always just informed guesses. I mean, they should be, and that's all they are. That if this and this and this and this is true, and by the way, one thing about power calculation, you always have to put down what did you actually assume, right? Then, so that somebody can reproduce it. Some of us are really picky. That's also the first thing we try to do is reproduce a power calculation, and if I can, then that's a big back point. But yeah, sorry, but it is an informed guess, and there's no need to pretend that it's not. So just like this is why I guessed it like this. That's why my sample size is. But you have to come up with a number. You cannot enroll 100 to 200 patients. You have to enroll X patients.
Yeah, not to be cynical here, but I could mention about playing the game, and I'm more interested in justifying animal protocols instead of human research. So would it be wrong to say, realistically, I have the resources to do, 20 mice per group, and just go backwards and say, with 20 mice per group, this is the power that I can get, and this is different, I mean, all the guesses are guesses anyways. It's 10%, 20% difference. There's no real scientific basis in justifying it either way. You can probably pull sources one way or the other to say that. So you just basically say, go back, say, look, I have the resources to do 20 mice per group with, blah, 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 and this is the power.
So I think there are two issues here. So if that's just your resources, then I think people don't look at it kindly generally because you always have an option of not doing the study, right? So if your resources do not allow you to get a meaningful answer, right, then you shouldn't be doing the study. Right? So with humans, it's a little bit sometimes different because there might be that the resources are there because there is a limitation, like you have that's how many patients there are. So there are the resources. But I think with animals, even weaker. On the other hand, sometimes we do say, okay, we have this, especially with secondary analysis, whatever, but that we have data on this many subjects, or we are doing a secondary analysis on a primary trial, right, which has its own power calculation. We are just doing additional analysis on this, and then we say, well, we can detect, we will have enough power to detect effects of this size. So we can do the back calculation, but then we say, we still have to argue that, and that effect size is clinically meaningful effect size. So it's not enough to say that will have 20% power. That's bad. That means you shouldn't be doing the study. Right? If you don't, but you might be able to do the back calculation and say, this is the effect size I can detect, and this is an interesting effect size.
Yeah, and if that's not that, you could always block your experiments, right? So if you can only have 20 animals per given time, then you block it. You do 20 and 20 and 20 to get what you need, okay? So you can design it that way. And I 100% agree. I say do less, but do it properly. Right? That's.
Well, I think what you're talking about, so there's always ways to kind of like game a power analysis, but I think what you're talking about is quite natural. Just to say, here's the resources we have and we think we could get. What can we do? And I mean, Aniko and I have had this conversation many times where I come in and I say, here's the 10 things I want to measure. And then we work together and figure out, she'll say, oh, you need 300 patients for this one. Okay, I don't think we're going to do that one. Let's move on. And you know, and eventually, I think so the current study, I think we said we were going to enroll 80 patients. Okay, so with 80 patients, how much power could we have, and what effect size could we detect for our primary outcomes? And I think that's just totally natural, and because it ultimately, like, it has to fit in a grant budget, unless the philanthropist comes along.
That's where I disagree. I mean, with clinical trials, I agree. But to answer your question, that's why I say do less, but do it properly. People say, well, I don't have the funds to do that. So that's not the experiment you should be doing, or you do away with another experiment and do this one properly. But whatever you do, you want to do the best you can. Okay?
Other questions?
I guess one other thing, just to follow up on that, if you are going to pick one, have you ever seen somebody say that number that you picked or that paper that you cited to pick that effect size for your power calculation is just so far off that your power factor is just wrong? Have you ever seen somebody do that, or that happened to somebody?
I had done that. I looked in the paper they cited, and it didn't have the numbers in it that they said it had in it, because
so it was just the number wasn't there, but it wasn't that it was too different of a study or too different of a model or something like that.
Well, so whenever you're citing something, the people who read have to find it convincing that this is realistic. So.
Have you ever had somebody say this isn't realistic?
Oh, so we had. I have seen studies when people were saying, well, yeah, they are powering it for such a huge difference. We don't think that whatever they are studying can actually deliver it. Right, so.
And presumably they had cited something that suggested that, right?
No, you don't necessarily. So sometimes for the difference they hope to, no, they don't cite anything.
Okay.
So even, like this treatment will improve, response rates from 10% to 40%. Okay, so you can do a sample size calculation for that and get a small sample size, but then reviewers will say, oh, I don't think so. We've done so many things and nothing ever improved.
So then, as long as the number is believable, you don't expect them to see something citing some other study that said that number is believable.
Well, but what makes it believable? I mean, not necessarily in this intervention, but there have been, that these things can actually be moved by that much. There have been interventions that done something, right?
So I've not personally, that I recall, seen the scenario you're talking about. And I think that a smoothly running study section will sort of tamp out maybe one person's vehement objection about something. I mean, that's not always true, but often, you know, you're in a room with a group of people for 2 straight days, and if somebody has a strong opinion, in general, people expect them to back it up. So, and if they can't, then that's what I mean about, you know, a smoothly running study section will usually kind of like dampen out some extreme opinions at times. Like, we all know examples where maybe that didn't happen, but yeah.
Well, I just, the only reason I mentioned is, again, going back to the reference you made of trying to find what that number was and find some basis in the literature for that number that they expect, and how much reviewers expect that to be based on prior literature versus just maybe some other number or some other reason why I expect that. As long as it's a believable thing to.
Sure. Okay, but the other thing that this is a resource that I'll just bring up to people. So my training in biomedical engineering was computational neuroscience, and so I do human subjects research, but I also do about half of my effort is simulation and modeling. And in 2016, the Food and Drug Administration in the US issued a formal document on inclusion of data from modeling studies in medical device submissions. I was completely blown away by this. I never thought I would see this in my life. And yet here's a formal document. Now, it's not a super precise document, but the point is that regulatory bodies, and I think scientific bodies, study sections as well, are more and more amenable to synthetic data that came from well-formed, well-executed modeling and simulation studies. And we'll certainly do that. I mean, not all the time, but we've certainly included synthetic data in our grant applications as justification, and that's gone okay. I mean, nobody has, when I started in this field 20 years ago, there were plenty of skeptics just about modeling across the board. They just said, I don't believe anything that comes out of the model. I don't get those criticisms anymore. They may not agree with what we did, but what I don't see anymore are people who just categorically object to modeling and simulation. So anyway, that's another resource to bring to bear in these kinds of situations. Okay, so why don't we stop there? Thanks everybody for participating. I learned a lot. I always do when I do these these types of workshops, and I also want to thank Aniko and Melissa and Andrew for helping today and also being participants. So thanks very much.